hi, everybody. Thank you for joining us to discuss the fifth case, which is triple negative breast cancer. We have with us today Dr. Elisa Krill from University of Miami, who's a medical oncologist. Thank you, Dr. Krill, for joining us.
Thank you.
Dr. Amanda Amin from University of Kansas, who's a breast surgical oncologist. Dr. Amin, thank you for joining.
Thank you.
And then Dr. Press from University of Southern California, who's a pathologist. Dr. Press, thank you for joining.
Thank you.
So just to jump into the case. So this is a 55-year-old woman who presents with a palpable left breast mass, who had her last screening mammogram 1 year ago, and she had heterogeneously dense breasts on mammography. She palpated 3 weeks ago a breast mass, and by physical exam, it was 2.5 centimeters in the largest dimension and was clinically node negative. She underwent breast imaging with a repeat mammogram and ultrasound. It was 2.6 centimeters. On ultrasound, there was some concerning features. She underwent an ultrasound-guided biopsy of the breast mass, which was poorly differentiated IDC. Triple negative as defined is ER 0%, PR 0%, and HER2 1+. And she has no family history, and she has a large family. So, Dr. Amin, if you wouldn't just talk us through what to do next.
Yes, I put this slide in here to remind the medical oncologist that your surgeons like to see these patients as early in the clinical course as possible if you're considering neoadjuvant chemotherapy. And for some of those reasons, for patients that meet criteria for genetic counseling and testing, this helps us determine the need for bilateral mastectomy for risk reduction when they have that future elevated breast cancer risk with pathogenic variants in BRCA1 or BRCA2 and PALB2. And for those patients that have dense breast tissue, such as our patient, those who carry genetic mutations and are at higher risk of that contralateral malignancy, and for those who you're considering neoadjuvant chemotherapy, bilateral breast MRI can be really helpful to define extent of disease. And this can also be used again to assess for end of treatment response. And a thorough assessment of their axillary nodal basins allows for appropriate management and possible opportunities for participation in clinical trials. These are the NCCN criteria for those who meet criteria for genetic testing. This was recently updated at the end of 2020. And in our patient with a personal history of breast cancer, even without a family history of breast cancer or ovarian cancer, because she was diagnosed with triple negative breast cancer under the age of 60, she herself meets criteria for panel testing. The reason for expansion for testing for patients up to the age of 60 in triple negative disease is because these patients do have a higher rate of identification of pathogenic variants. BRCA1 is identified in 7 to 28% of patients with triple negative disease, BRCA2 in 1 to 17%, as well as other genes such as RAD51C, RAD51D, BARD1, and BRIP1. She does undergo panel testing and is negative for an actionable pathogenic variant. She has bilateral breast MRI performed. She has relatively small breast. She wears a B cup in her bra. Her right breast and nodal basin are within normal limits. In the left breast, she does have a discretely enhancing mass in the upper outer quadrant that contains her biopsy clip, and it measures up to 3.1 centimeters in largest extent. Ultrasound is better than MRI at assessing her axillary lymph nodes. So she has an ultrasound that demonstrates that single level 1 axillary lymph node with abnormal cortical thickening and loss of a fatty hilum. And this does undergo ultrasound guided percutaneous biopsy with clip placement. And the pathology from this is also positive for triple negative breast cancer. When considering a surgery first approach compared to neoadjuvant chemotherapy, the benefits of neoadjuvant chemotherapy from a prognostic standpoint will be discussed in the slides to follow. So from a surgeon's perspective, this gives us the benefit of time. It allows us to obtain genetic testing when appropriate. It allows us to coordinate with our plastic surgeons for reconstruction if this is needed. And it also, particularly with triple negative breast cancer and HER2 positive breast cancer, allows us to facilitate breast conservation, especially in those smaller breasted women like our patient, and allows us to downstage the axilla, allowing us to omit full axillary lymph node dissection when appropriate.
Thank you. So, Dr. Press, if you wouldn't mind just talking us through her pathology and some considerations in terms of determination of triple negative breast cancer, and also the consideration of when trying to define HER2 status.
So this histopathology in front of us is one of a relatively poorly differentiated breast cancer in which there are an absence of gland formation, relatively pleomorphic nuclei, and an elevated mitotic rate. There's a rich inflammatory cells are also present. So this is a poorly differentiated invasive breast cancer. So as a way of illustrating some of the issues related to testing and establishing, first of all, that the patient has triple negative disease, I'd like to focus a little bit on the establishment, especially of HER2 negative disease, and use a case that was referred to us recently. This was a 70-year-old woman who had biopsy-proven infiltrating ductal carcinoma and had a right-sided breast lumpectomy for a 2-centimeter mass at 10 o'clock and a sentinel lymph node biopsy. The breast cancer was identified as being ER negative, PR negative, having a high proliferative rate, and was considered to be HER2 positive by immunohistochemistry and was called 3+ positive. And because of issues in the case, it was referred for further evaluation. And if I could have the next slide. One can ask, is based on this, would you treat this patient as HER2 positive disease? And the clinician had some reservation about it. And the next, because they had also performed a dual-ish assay, in situ hybridization that was bright field, that did not confirm that the case was HER2 amplified by a bright field analysis, it was referred for a second opinion. And so in the next slide, you'll see an example of the outside slides for hematoxin eosin histopathology, staining of a poorly differentiated invasive breast cancer. The immunohistochemistry from was identified membrane staining in a circumferential fashion throughout. This was performed with the 4B5 FDA-approved immunohistochemical assay. As you see in the second and third panels, moving from left to right at progressively higher power. And then finally, the dual in situ hybridization assay that did not demonstrate gene amplification is shown at the fourth panel to the right. And then when we reanalyze this breast cancer sample in our laboratory, the next slide shows the results of those analyses. I'm sorry, if you back up one, there's one thing that was not discussed that's worth noting, is that in this specimen, the benign ducts that were present also showed membrane staining for HER2, which suggests that the assay was either very sensitive or that antigen retrieval was used at a relatively high rate to elevate the immunohistochemical staining in this particular specimen. And then the next slide shows our analysis of this case. Beginning on the left-hand side is an immunohistochemical assay for a laboratory-developed test that shows a high correlation with gene amplification. You'll notice that membrane staining is reasonably difficult to find. It's quite low. In the middle panel is HER2 immunohistochemical assay with the DACO-HERCEP test, which was read as 2+ positive in the tumor cells. And then finally, to the right-hand side, using fluorescence in situ hybridization, the average HER2 copy number was less than 4, the ratio was less than 2, and it was interpreted as HER2 not amplified. and the case was overall interpreted as having low expression for the protein product. So this raises the issue about HER2 testing in these to make sure that it's assessed initially in the most appropriate fashion. And the next slide demonstrates some of the issues that are raised for HER2 testing according to the algorithms of the ASCO-CAP guidelines. This shows a comparison of the ASCO-CAP guidelines for HER2 testing by immunohistochemistry in 2007, and then as they were revised minimally in 2013 and 2014. And if one clicks through this, then some of the high points of this are that fixation was altered from 6 to 48 hours, and then subsequently in the next click, you'll notice that it was increased to 72 hours. These are relatively modest changes in the overall guidelines. And then further, the percentage of cells that were required for HER2 positive disease was raised from 10 to 30%. And then in 2013, 2014, it was reduced back from greater than 30% to greater than 10%. However, the important change, I think, is shown on the next click, which is that in 2007, there was a required concordance analysis to demonstrate that if immunohistochemistry for 0, 1 plus, and 3 plus were going to be used, the assays needed to be compared with fluorescence in situ hybridization and demonstrate that there was a 95% concordance or agreement between 0, 1 plus being less than 5% amplified and 3 plus being greater than 95% amplified in order to use the immunohistochemical assay in the relevant laboratory. In 2013 and 2014, this 95% concordance rate was no longer required, and it was up to the lab discretion to be able to make a determination of what was the appropriate agreement rate for the laboratory. And in the next slide shows the current guidelines in 2018 and compared to 2013 and 2014, which are essentially unchanged. And in the next click, there is the point here is that in 2007 through 2018, they really don't address the issues of false negative and false positive results by immunohistochemistry for HER2 status. And so this is a consideration, and this shows an example summarized from the world's literature in which we have at least 100 cases that are compared in each one of these studies that compare immunohistochemistry with HER2 status for gene amplification determined by FISH. And so in 0 and 1 plus and in 3 plus, there should be a 95% agreement rate. And as one clicks through this, the boxes, the little red boxes that will appear demonstrate those cases that do not have a 95% agreement rate. So the amplification rate for these IHC 3 plus cases is less than 95% in each of the boxed areas. Similarly, on the 0 and 1 plus, if we click through, the box studies demonstrate a greater than 5% amplification rate in those cases that are 0 and 1 plus, and indicating that there are a significant number of cases in the published literature in which this agreement rate is not met using immunohistochemistry by an established laboratory. The following slide demonstrates the scoring for HER2 gene amplification by FISH, in which the HER2 probe is identified with a red fluorophore to bind to the DNA sequence of HER2. Chromosome 17 centromere is identified by a green fluorophore, and the number of signals for both HER2 in red and chromosome 17 centromere in green are simply enumerated, and then the ratio is calculated. And when that ratio is less than 2, it's considered to be HER2 not amplified. When the ratio is greater than 2, it was originally considered to be HER2 amplified. And then the current guidelines are, if we can show the next slide, please. This shows a direct comparison that was published in the past comparing immunohistochemical assays and with FISH assays from a cohort of breast cancer patients that were established by independent molecular means as being either HER2 amplified or HER2 not amplified. And so there were 117 cases that were used for this comparison. And in the next click, you'll notice that 2 of these cases that were known to be amplified by southern blotting and overexpressed at the RNA level and the Western immunoblot level, as well as frozen section immunohistochemistry, demonstrates that in the upper series of panels in the first click, and then the next click that shows 2 cases from paraffin-embedded tissue sections. One more, please. All 6 of these assays show a positive result in a known positive case using frozen tissue samples. However, in the bottom on the next click, the 6 panels show 2 positive results on the left-hand side by 2 different fluorescence in situ hybridization assays. But the 4 immunohistochemical assays, 2 of the right-hand panels on 2 panels are FDA-approved assays, neither of which show positive membrane staining for the tumor cells. One of the 2 laboratory-developed assays show positive membrane staining in a case that's known to be HER2 amplified with overexpression. So this points out some of the issues that are related to HER2 testing using different assays. The next slide, please. Shows a consideration of clinical outcomes for patients in which the immunohistochemical assay was interpreted as 0 or 1 plus, but HER2 gene amplification was demonstrated in this cohort of cases. Approximately 8% of the cases that were interpreted as IHC 0 or 1 plus were HER2 amplified by FISH. And these patients, over an extended period of follow-up, had significantly worse distant disease-free survival. And the next slide shows the reverse of that. This is from the pivotal trials of trastuzumab that were published in 2001, where immunohistochemistry at 2 plus or 3 plus with a laboratory-developed assay was required for entry to the trial, and the patients were treated either with trastuzumab or Herceptin plus chemotherapy or chemotherapy alone. And when these samples the tissue samples from this trial were retrospectively evaluated by fluorescence in situ hybridization on the next click, those cases that did not have gene amplification by FISH are shown in the lower right-hand portion of the slide, and they did not demonstrate a significant benefit in terms of overall survival by adding trastuzumab to the chemotherapy. In contrast, on the next click, those cases that were immunohistochemistry 2 plus or 3 plus and had gene amplification by FISH showed a further separation in terms of the outcome for overall survival. And the next click shows that if these are superimposed on the original plot, the p-value is more statistically significant and the separation in the outcomes is further separated, enhancing the improvement within the clinical trial. So gene amplification assessment does add something. The assessment of HER2, please, the next slide. So the assessment of HER2 gene amplification by FISH is shown here from 2013, in which there were 5 different groups that were determined by HER2 ratio greater than 2 and average HER2 copy number greater than 4 or less than 4, shown in the left-hand 2 groups. You can click through. And then when the ratio between HER2 and chromosome 17 was less than 2, the average copy number greater than 6, this was interpreted in 2013 and 2014 as ISH positive, when it was between 4 and 6 as ISH equivocal. And then finally, when the HER2 average copy number was less than 4 as HER2 negative. And if we can advance the slides, groups, then those can be, I'll refer to them as group 1, then group 2, group 3, group 4, and group 5. And then subsequently on the next slide, the correlation of these groups with immunohistochemical staining is summarized for the same groups that are shown across the top panel that demonstrate where the statistically significant correlations are found with immunohistochemistry. Only group 1 shows a statistically significant correlation with 2+ or 3+ immunohistochemical staining. Groups 2, 4, and 5 show a significant correlation with a lack of overexpression by immunohistochemistry, while group 3 can be divided into 2 different subgroups. One that's positive at the bottom, panels H and I, that have gene amplification by FISH and overexpression by immunohistochemistry, and F and G that have neither, even though they have greater than 6 average copies of HER2 per tumor cell. Next slide, please. And if you can continue to click through the red boxes, groups 2, 3, 4, and 5. And then on the next slide. So currently in 2018, we're assessing group 1 as amplified and group 5 as HER2 negative, whereas groups 2, 3, and 4 are being further worked up using immunohistochemistry, as is shown in the next red box. And if we can advance the slides, please. So group 5 is considered to be negative, whereas group 1 is considered to be positive. And then please, the next one. Okay.
Thank you for reviewing that. That was extremely helpful. So, Dr. Krill, if you wouldn't mind just talking to us a little bit about where things are with neoadjuvant therapy, in particular, where things are in terms of adding in immunotherapy and studies supporting its potential application for patients.
Sure, thanks. So medical oncologists love neoadjuvant chemotherapy too. It definitely benefits our patients, especially in terms of downstaging the axilla. So the patients will have a decreased chance if we can downstage the axilla for lymphedema. We also love that, that we know patients who have a pathologic complete response will have a better prognosis, and those that do not, we can offer them further therapies to improve their prognosis. So in the Keynote 522 study, patients with stage 2 or greater triple negative breast cancer were randomized in a 2-to-1 fashion to neoadjuvant chemotherapy backbone of paclitaxel and carboplatin, followed by doxorubicin or epirubicin and Cytoxan. The patients were randomized 2-to-1 to either receive pembrolizumab or placebo prior to surgery along with the chemotherapy backbone, and then after surgery continued their study drug for a period of a total of a year. The patients were stratified by nodal status, tumor size, and by carboplatin schedule, as they could have carboplatin every 3 weeks or on a weekly basis. Next slide. So as you can see, the baseline characteristics were well balanced between the pembrolizumab group and the placebo group. About 40% of the patients received weekly carboplatin and about 60% Q3 week. About 83% of patients in both arms were PD-L1 positive. And the majority of patients had T1 to 2 tumors, and a little over 50% in both arms had nodal involvement. Next slide. And the definitive PCR analysis of the intent to treat group showed an improvement of 13% absolute value in pathologic complete response in patients who were randomized to the pembrolizumab group. PCR was defined as no tumor in the breast or in the axilla, or just having residual DCIS. Next slide, please. And in the pre-planned interim analysis for event-free survival, what you can see is that there's about a 6% improvement in event-free survival over 18 months, at 18 months. This is very exciting as it is one of our first neoadjuvant trials that shows improvement in event-free survival for the addition of an immune therapy agent or an additional agent. Next slide. Interestingly, if you look at PCR by disease stage, what you can see here all the way to the right is in stage 3B, there's a 25% improvement in pathologic complete response rate between the placebo group and the pembrolizumab group. Whereas all the way on the left in the 2A patients, there's only about an 11% benefit. So it seems that the pembrolizumab is improving the prognosis in our highest risk patients. Next slide. PCR again by lymph node involvement. Patients who had negative lymph nodes only had about a 6% improvement in their pathologic complete response rate. But in patients who had lymph node involvement, there was a 20% absolute improvement in pathologic complete response rate. Again, it appears that the addition of an immune checkpoint inhibitor is improving the pathologic complete response rate and hopefully the prognosis in our highest risk triple negative breast cancer patients. Next slide. So if you look at this by PD-L1 expression level, what you can see here is there's a benefit in patients who have PD-L1 negative tumors as well as PD-L1 positive tumors. Now, again, the vast majority of patients in this trial with early breast cancer did have PD-L1 positive tumors. But if you look all the way to the left, patients with CPS scores of less than 1, so they were PD-L1 negative, still had a 15% absolute improvement in pathologic complete response rates if they had pembrolizumab. And again, if you look at the patients with CPS greater than 10, CPS greater than 20, there's a 19% improvement in the highest risk group. But again, we see improvement in all subgroups of patients with PD-L1 expression levels. Next. Now, the downside of this therapy, obviously no therapy comes without a cost, and we do see significant side effects in these patients. So the vast majority of side effects are hypothyroidism. About 15% of patients who got pembrolizumab developed hypothyroidism. And as we know, this is a lifetime side effect for them. We saw a lot of skin reactions as well during therapy, some hyperthyroidism, and worrisomely, we saw 2.7% of adrenal insufficiency. Now, the more severe immune therapy reactions are quite rare. Colitis, pneumonitis, and hepatitis are all under 2%, but this is not a freebie therapy. We do see side effects. We do have to stop this therapy in some patients. And there are stranger side effects. I've recently seen a patient develop severe myositis from this and couldn't walk, and we had to stop her therapy. Fortunately, she had a pathologic complete response. But I think, we have to be very, very cognizant of these side effects. We have to be on the watch for them. Patients are often fatigued on neoadjuvant therapy, but we have to have a low threshold to check their cortisol levels and make sure that they're not really having adrenal insufficiency, which could be life-threatening if we do not catch it. So it's a new for us in the breast cancer field, although in most other malignancies now, we're using a lot of immune therapy. So for breast oncologists, it's something we're less familiar with and have to get more familiar with. Only 6% of patients, though, had to discontinue the drug because of these side effects. Next. Again, in the I-SPY trial, you can see very similar results. The vast majority of side effects were hypothyroidism, hyperthyroidism, and interestingly enough, adrenal insufficiency, which seems to be more common in our breast cancer trials than we see it in other malignancies. And again, the very severe immune therapy side effects of hepatitis, pneumonitis, and colitis are small, but they're there. Next slide. So a second trial looking at neoadjuvant chemotherapy with an immune checkpoint inhibitor was the IMpassion031 trial. This was a phase 3 trial looking at atezolizumab neoadjuvant in triple-negative breast cancer. Again, this looked at patients with at least stage 2 tumors. PD-L1 status was checked. They were stratified by their stage and by their PD-L1 status. Now, the backbone of this trial was a little bit different. There was no platinum therapy used in this trial, and the patients were given nab-paclitaxel as opposed to paclitaxel. So the therapy was nab-paclitaxel weekly, followed by adriamycin and Cytoxan therapy with or without atezolizumab. After completion of the neoadjuvant chemotherapy, the patients went to surgery, and then they continued atezolizumab if they were on that arm of the trial for the completion of a year of therapy or observation. The primary endpoints were, of course, pathologic complete response and event-free survival, disease-free survival, and overall survival in both the intention to treat and the PD-L1 positive subgroups. Next slide. So for the endpoint of pathologic complete response, you can see that the improvement in pathologic complete response was about 15–16%, which is very, very similar to the KEYNOTE trial, although the absolute value of the pathologic complete response is slightly lower. Next slide. And again, if you look in PD-L1 positive versus PD-L1 negative tumors, the PD-L1 positive tumors are on the left-hand side, and the PD-L1 positive tumor had a response rate with atezolizumab of 68% versus 49% without atezolizumab. And it's significantly lower in the PD-L1 negative subgroup, about 48% versus 34%. So what it appears is that the atezolizumab, the immune checkpoint inhibitor, improves the prognosis, improves the pathologic complete response rate in both the PD-L1 negative and the PD-L1 positive subgroups. Although PD-L1 positivity does appear to be a marker for improved prognosis with chemotherapy alone or with chemotherapy plus an immune checkpoint inhibitor. So it appears to be a marker of better response to therapy, although there is an improvement even in the PD-L1 negative subgroup. Next slide, please. So in the IMpassion031, the event-free survival is not yet mature. Neither is overall survival, but there is a trend toward improvement in prognosis in patients who got the atezolizumab arm of the therapy. Next slide.
Thank you. That was an excellent review. Before moving on, we're awaiting for approval of checkpoint inhibitors in the neoadjuvant setting, and we'll see whether we have, utilization of, for instance, pembrolizumab in the next couple of months. One question, just when considering these data, if we have approval of checkpoint inhibitors, do you feel like you will always utilize a platinum? Do you feel like, given the results of the IMpassion study and then also the smaller study with the I-SPY2 trial where patients did not receive carboplatin, where we saw some statistically significant improvement in PCR, how are you discriminating which patients you will be utilizing carboplatin?
Well, they sound like our tumor board where we discuss this a lot. At this point in time, we have been, as it is not FDA approved, we have been reserving immune checkpoint inhibitor to our highest risk patients. So the patient I spoke about before, had bilateral triple negative with multiple nodes positive. So I felt the risk was definitely worth the benefit in her. Clearly, we're not recommending it in stage 1 disease. And, if you look at the absolute improvement in a pathologic complete response rate, in the node negative population, in the smaller tumors, you really don't see that great an improvement in pathologic complete response rate. And again, I think that's how we've thought about carboplatin as well. that in the positive node group, we really want to downstage them, to maybe minimize their chance of needing a full axillary dissection. So I think that's something that we are going to have to work out. I think at this point, patients with positive nodes will probably be the group that I would recommend it with. I think it probably doesn't matter as much if we're going to add the platinum, because there's been some trials with platinum and some without, and there's an improvement in both subgroups. And as of yet, we haven't seen a consistent improvement in event-free survival with the addition of carboplatin. Is that how you would look at it?
I think that was really quickly stated. And, also before moving along with the case, I also, as you were talking about your one patient who had myositis, I had one patient who had significant red cell aplasia and required almost 24 red cell transfusions. And, it just takes that one very unusual case to make, just to reiterate how we need to be thoughtful in terms of who we're where the risk benefit ratio is and who we're considering.
And I inherited a stage 1 patient that actually in the community was started on immune therapy with her neoadjuvant therapy. This was somebody with a T1CN0 tumor, and she developed a Bell's palsy, actually. Luckily, it resolved, but this is not entirely benign therapy.
Right. So, thank you. Moving along. So this patient received neoadjuvant dose-dense ECT. And then following chemotherapy, she had an excellent clinical response at the end of her treatment, and her MRI demonstrated complete imaging response both in the breast and the axilla. So, please.
I was just going to say, we'll talk about management of the axilla here, but I do want to mention, there are patients who are always asking, well, if I have a complete response on imaging, why do I need a breast surgery? And we have asked this question. The NRG Oncology BR005, which was presented at San Antonio in 2019, attempted to answer this question. This is a phase 2 trial that opened in 2017, and it was designed to assess the accuracy of a tumor bed biopsy to predict the pathologic response in patients who had clinically and radiographic complete responses. So in these 105 patients that underwent image-guided biopsies, and which were then followed by breast surgery, the negative predictive value of their biopsy was only 77.5%. So this indicates that a negative biopsy missed residual disease in 22.5% of patients. So it missed the pre-specified threshold of greater than 90%, and so therefore it does not support the feasibility of initiating a study where breast surgery can be omitted at this time. So everyone without distant disease should proceed with breast surgery, and we'll talk about the breast surgery choice in just a minute, but first I wanted to cover the management of the axilla for these patients who are receiving neoadjuvant chemotherapy. So these are the NCCN guidelines from 2020 for patients with clinically node-positive disease. Standard of care would have been if she had proceeded with surgery first for axillary lymph node dissection, but because it appears to be clinically, because pathologic response in the axilla is so high for patients receiving neoadjuvant chemotherapy, and with triple negative breast cancer, this ends up being around 50%. And with the morbidity being high associated with axillary lymph node dissection, the need to proceed immediately to axillary lymph node dissection has been appropriately called into question. So now that she's had an excellent treatment response, she can consider proceeding with sentinel node biopsy as justified on this algorithm here. So ACOSOG 1071 was the trial that was used to determine the feasibility of performing sentinel node for these patients who are clinically node positive and then have neoadjuvant chemotherapy. All the patients in this trial had sentinel node, which was followed by completion axillary lymph node dissection. 41% of these patients had a nodal PCR, and the overall false negative rate was 12.6%, which was above their pre-specified threshold of 10%. However, this was lowered when they looked at patients who had mapping using dual tracer, those patients that had greater than 2 lymph nodes removed, and those patients that had a biopsy clip left at the time of their diagnosis and their positive lymph node, and that biopsy clipped node was retrieved. Additional prospective multi-institutional trials such as Sentina and the SNFNAC have also published similar results supporting the use of sentinel node in this patient population. So our patient had genetic testing, which was negative for a pathogenic variant. She's had an excellent clinical response. And so she elects to proceed with breast conservation, knowing that she does need a breast surgery. And with complete imaging response in her axilla, she has localization of her previously biopsied lymph node with radioactive seed and proceeds with a sentinel lymph node with dual mapping. And in her final lumpectomy specimen, there's 0.5 centimeters of residual invasive cancer, and she has 3 lymph nodes retrieved, which are all negative for malignancy, one that has a biopsy site and treatment effect. So these are the clinical trials for management of women who have clinically positive nodes who convert to clinically negative nodes with neoadjuvant chemotherapy. The first is Alliance A11202. Which is a phase 3 randomized clinical trial comparing regional nodal irradiation in addition to axillary radiation compared to axillary lymph node dissection for women with persistent positive nodes after neoadjuvant chemotherapy. They cannot have had a sentinel lymph node before neoadjuvant chemotherapy, so all nodal staging should be reserved for after neoadjuvant chemotherapy. Primary endpoints were invasive recurrence-free survival, and secondary endpoints are overall survival and local recurrence. The expected completion date is 2024. And then for women who convert to pathologic node negative, such as our patient, they should be considered for the sister trial. So clinically node positive, good treatment response, and then our pathologically node negative. This is NSABP B51 or RTOG 1304. This is comparing, it's a phase 3 trial, again, randomized controlled, investigating the ability of regional nodal irradiation to improve recurrence-free survival. All women must be node negative and could have either sentinel node or axillary lymph node dissection and are randomized to receive either regional nodal irradiation or no regional nodal irradiation. And the expected completion date is 2028 with the same endpoints.
Thank you. So one question before just moving on. So, outside of a clinical trial, when you're thinking about management of the axilla, do you think differently in terms of somebody who presents with a clinically palpable lymph node as opposed to somebody who has, imaging detected axillary lymph adenopathy that's then determined to be pathologically involved? And how do you incorporate that decision making in your practice?
For patients that will receive neoadjuvant chemotherapy, such as those who are triple negative or HER2 positive, really a good thorough assessment of the axilla is important. So whether it's palpable or whether it's abnormal on imaging, that needs percutaneous biopsy and treated as such. If patients are proceeding with surgery first, such as hormone positive HER2 negative patients, if the axilla is not palpably abnormal and they're proceeding with breast conservation, I typically apply Z11 under those circumstances because imaging was not used to assess axillary staging.
Thank you. So moving along, Dr. Krill, if you wouldn't mind just talking to us about the CREATE-X trial and its implications.
Sure. So the CREATE-X trial had a population of patients who had had neoadjuvant chemotherapy followed by surgery and did not have a pathologic complete response. The trial did take patients who both had estrogen receptor positive disease and patients who had triple negative disease. They were randomized to standard of care or standard of care therapy plus capecitabine at full doses for 6 to 8 cycles of therapy. And they were stratified by ER status, age, neoadjuvant chemotherapy, and pathologic nodal involvement. And what is found is that there was a marked improvement in both disease-free survival and in overall survival in the hormone receptor negative group. So this appears to be a really good way of improving our survival rate in our patients who have triple negative breast cancer who have not achieved a pathologic complete response to therapy. So, you know, people will often want to add carboplatin initially, which has not been shown consistently to improve DFS or overall survival. Whereas we can take the smaller group of patients who do not achieve a pathologic complete response and give them 4 to 6 months of capecitabine afterwards and actually improve their prognosis. Next. So we also have some current ongoing trials for patients who do not achieve a pathologic complete response. So the SWOG 1418 trial randomizes patients who have non-metastatic triple negative breast cancer that have more than 1 centimeter of residual invasive carcinoma after neoadjuvant chemotherapy to pembrolizumab or placebo. Or observation. And the primary endpoints, again, are invasive disease-free survival and side effects it's looking at for this trial. Secondary endpoints are, of course, overall survival, safety, and distant recurrence-free survival. Next.
So, you know, based upon these data, the patient receives 6 months of capecitabine, and then she, 9 months later, develops distant disease. So she has an early relapse where she presents with liver, lung, pleural effusion, and bone lesions throughout the spine. She continues to have an excellent performance status, and the scans have been prompted because she has some mild shortness of breath with exertion. And at that time, she had a normal echo, and then they were ruling out a pulmonary embolus, but she had no signs of pulmonary emboli, but yet had these lung and pleural findings. And the pleural effusion was TAT, and she was ER0, PR0. Let's say she's HER2-0 and a Ki67 of 25%, and she had PD-L1 tested with the SP142 assay. So Dr. Press, if you wouldn't mind just talking to us a little bit about PD-L1 and how to analyze for this.
So there are currently 5 different immunohistochemical assays that are used for evaluating the status of PD-L1 for immuno-oncology. And these are in non-small cell lung cancer, bladder cancer, melanoma, head and neck squamous carcinoma, kidney cancer, Merkel cell carcinoma, upper GI cancer, cervical cancer, hepatocellular, and breast cancer, triple negative breast cancer. And on the next slide is an example of how 3 of these immunohistochemical assays compare to one another. And although there is substantial agreement among them, there are also differences. So this shows examples of 3 of these assays, 2 of which are show more agreement than the others. So the 28-8 assay and 22C3 show more agreement than the SP142 assay. So these particular 6 panels that were published in a recent paper in Human Oncology, Human Pathology, that came out this month, shows a comparison of 98 triple negative breast cancer samples and their correlation with regard to each one of these immunostaining characteristics, both for the tumor cells and for the immune cells. This panel of 6 different cancers shows some of the variation that can be found among them, both for immune cells and for tumor cell immunostaining for PD-L1. And then if we look on the next slide, is a summary in a form that shows the comparison of these 3 different immunohistochemical assays. In A is a comparison of immune cell scores with the darker color for each one of the assays representing those that are positive. And among the same cases, 28-8, 22C3, and SP142 are compared with one another. And although there is a considerable agreement, there are also some differences. Likewise, for the tumor cell score And then at the bottom for the combined tumor cell and immune score, the so-called combined positive score. So the agreement rate approximates 90% for these throughout, the concordance rate. And so it varies from fair agreement to a very high level of agreement, depending on which of these are evaluated. So I think in closing for these, it's worthwhile considering that one should consider the drug that's going to be used, and these drugs are then paired with a particular PD-L1 immunohistochemical marker, and it's worthwhile using that particular immunoassay for the drug that's being considered for subsequent therapy. Thank you.
Thank you. I think that that's a really important point, right? That these are diagnostics for particular drugs. So if you're using atezolizumab, one should be checking, if you're going to be, you should be checking SP142. If you're going to be utilizing pembrolizumab, one should be looking at the Merck assay. Thank you. And to kind of go into some of these data, Dr. Krill, if you don't mind just talking us through the studies that led to the approval of checkpoint inhibition in patients with PD-L1 positive, triple negative metastatic breast cancer in the frontline setting.
Absolutely, thank you. So the Impassion 130 study looked at patients with metastatic triple negative breast cancer. These patients were randomized 1-to-1 to atezolizumab plus nab-paclitaxel or placebo plus nab-paclitaxel. And they were stratified by prior taxane use, liver metastases, and PD-L1, looking at both progression-free survival and overall survival, as well as overall response rate and duration of response. Next. And what you can see here in the PD-L1 positive subgroup, there was a marked benefit in progression-free survival. So progression-free survival, median progression-free survival increased from 5 to 7.5 months in the atezolizumab arm versus the placebo arm. Next. Overall survival also increased. So if you look here, the overall survival increased from 15 months to 25 months, the median overall survival in the atezolizumab group. So this really has moved the bar for our patients with PD-L1 positive metastatic triple negative breast cancer. This is a clinically meaningful result for this subgroup of patients. Next slide. Now, unfortunately, that doesn't include all of our triple negative breast cancer patients. In the PD-L1 negative subgroup, which you can see here, is there was absolutely no benefit in progression-free survival. Next. And again, in overall survival, again, no benefit. But in the PD-L1 subgroup, there was a sustained improvement in progression-free survival. And this did lead the FDA to approve atezolizumab for metastatic PD-L1 positive metastatic breast cancer using the appropriate Ventana assay. Now, there was a follow-up study to this, Impassion 131, which instead of nab-paclitaxel actually used paclitaxel. And that did not show a benefit in the PD-L1 subgroup. So the FDA has cautioned that if one is to use atezolizumab for a PD-L1 positive metastatic patient, to always use nab-paclitaxel as opposed to paclitaxel for this group of patients. Next slide. Now, another study looking at pembrolizumab in this population was the Keynote 355 study. A very similar study, patients were randomized 2-to-1 to pembrolizumab plus chemotherapy of doctor's choice or placebo plus chemotherapy of doctor's choice. And the physician's choice chemotherapy could either be nab-paclitaxel, paclitaxel, or carboplatin and gemcitabine. Patients could not have had any therapy in the metastatic setting, but they could have had adjuvant therapy. And again, a large subgroup of these patients did see taxanes in the adjuvant setting. The patients were stratified by chemotherapy on study, although the study was not powered to look at differences in the chemotherapy arm. And again, because they were not randomized, one would assume that patients who had received taxanes um, for their adjuvant therapy and more recently may have been overrepresented in the carboplatin gemcitabine group. They were also stratified by PD-L1 tumor expression with CPS score greater than equal to 1 or less than 1, and prior treatment with the same class of therapy. Next. Now, what you can see here in the patients with CPS scores of greater than or equal to 10, there was a marked improvement in median progression-free survival, a 4-month improvement in progression-free survival from 5.6 months to 9.7 months. Next. And if you look at the subgroup of patients with CPS scores, back one. Skip forward, CPS scores of greater than 1. There was also a smaller improvement in progression-free survival, but it was statistically significant of 5.6 to 7.6 months. Next. Now, if you look at the progression-free survival by the chemotherapy used, what you can see here is that there was an improvement no matter which chemotherapy the patients got. So unlike in the impassioned studies, we did see an improvement in progression-free survival in both the nab-paclitaxel group and the paclitaxel group. We also saw an improvement in gemcitabine and carboplatin. Now, I caution you when you look at these results not to assume that there isn't an improvement in carboplatin and gemcitabine along with pembrolizumab. The trial was not powered to look at this, but among all chemotherapy groups, there was an improvement in progression-free survival, especially in the CPS greater than 10 arm. Next. So with this, the FDA, has approved pembrolizumab with any of those 3 chemotherapies for patients with CPS scores greater than 10.
Thank you. So this patient ends up receiving nab-paclitaxel and atezolizumab, but then develops adrenal insufficiency. And, perhaps given the keynote data, one would have considered the fact that this was an early relapse, maybe doing something that you had mentioned, of maybe giving pembrolizumab along with carbo gem, but understanding that we would have needed to see that the appropriate assay demonstrated PD-L1 positivity. So in the last remaining 10 minutes or so, if Dr. Krill, if you don't mind just reviewing some additional data, let's move beyond just checkpoint inhibition and talk about other things that are coming down the pike or have been approved in patients with triple-negative breast cancer.
Yeah, absolutely. I mean, it's sort of sad to call the disease triple-negative breast cancer because we don't know what it's positive for, but we're starting to get a better idea, which is certainly helpful. I mean, we now have agents for triple-negative breast cancer that's PD-L1 positive. We also have 2 new antibody drug conjugates, which one of which is already approved and another of which is in trials. And a third of which is approved for HER2 positive disease. We have PARP inhibitors in patients who have germline BRCA mutations. And we also have some data that in patients who have somatic BRCA and germline PALB2 mutations may also respond to those. And we've also seen in trials that AKT inhibitors, capivasertib and patisertib, in combination with paclitaxel in first-line therapy of metastatic triple-negative breast cancer, show improvement in prognosis in patients with PIK3CA, AKT, and PTEN altered tumors. So we're starting to see what a triple-negative breast cancer may be positive for and how to improve prognosis. Next slide. So this is a cartoon of how an antibody drug conjugate works. When I'm talking to my patients about this, they're fascinated. I like calling it kind of the Trojan horse approach. What you find is that the antibody drug conjugate binds to the antigen on the breast cancer cell. It's then internalized to the cell in an early endosome. the degradation of the antibody drug conjugate occurs in the lysosome, and the payload is released from the antibody. The payload is toxic to the cell. It's released, it kills the cell. You see apoptosis of the cancer cell, and then also some of that payload can leak out of that dead cells area and kill bystander cells, which may not have as high an antigen load to endocytose the antibody drug conjugate themselves. Next slide. So recently approved was sacituzumab govitecan, which is a humanized anti-TROP2 antibody. So TROP2 is an epithelial antigen that's expressed on many solid tumors, including triple-negative breast cancer. 88% of triple-negative breast cancers express TROP2. It has an SN38 payload, which is a compound related to irinotecan, but when delivered by the antibody drug conjugate, delivers 136-fold more SN38 than irinotecan can when given peripherally. The linker is a hydrolyzable linker, and there's a very high drug to antibody ratio of 7.5 to 1. Next slide. So in a single arm open label trial, sacituzumab govitecan was given every 21 days until progression. Next trial, next slide. And you can see in this waterfall plot that overall response rate was 33%, but clinical benefit rate was 45%, and the vast majority of patients actually responded to this drug in a very heavily pretreated triple-negative population. Next slide. So the ASCENT trial was conducted. The ASCENT trial was patients with metastatic triple-negative breast cancer, all of whom had greater than or equal to 2 chemotherapies for advanced disease. So again, these were fairly heavily pretreated patients who were randomized to treatment of physician's choice or sacituzumab govitecan, primary endpoint being progression-free survival, and secondary endpoints, duration of response and overall survival. Next slide. You can see here that the drug does have some toxicities. It causes neutropenia, it can cause anemia, a small amount of diarrhea, although very little grade 3 diarrhea, some nausea, fatigue, and about half the patients did develop alopecia. Next. Now, this trial was stopped early because of the progression-free survival advantage. So progression-free survival was markedly improved in the patients randomized to the antibody drug conjugate, 5.6 months versus 1.7 months. Next slide. Overall survival was also significantly improved from 6.7 months to 12 months. Next slide. And as you can see here, again, the vast majority of patients actually responded and had clinical benefit with the sacituzumab govitecan as opposed to the chemotherapy of physician's choice. And the duration of response was about double, from 3.6 months to 6.3 months. Next slide. So just to let you know what new is happening, this drug is also being looked at in the TROPiCS-2 trial for hormone receptor positive metastatic breast cancer. This trial has recently closed and we are awaiting results. Next slide. Now, another antibody which has not been approved yet is ladiratuzumab vedotin. I think I can say that. Now, this is a LIV-1 antibody. LIV-1 is a zinc transporter, and the payload is a microtubule disrupting agent called monomethyl or statin E. This is currently in trials in patients with greater than or equal to 2 prior metastatic regimens who have LIV-1 expression on their cells. Next slide. Again, when they screen patients, 90% of triple negative patients were positive for the LIV-1 LIV-1 antigen. Next slide. And you can see here in the phase 1 trial that about half of the patients did have clinical benefit, 25% had an overall response. Now, a drug that's already approved for HER2 positive breast cancers is trastuzumab deruxtecan, which is a very potent HER2 positive antibody drug conjugate. And it is being looked at in HER2 low tumors. So we have a new classification of tumors called HER2 low, which are tumors that stain HER2 1+ and 2+. And what you can see here is a confirmed overall response rate of 50% in these HER2 low tumors. And as you can see, the vast majority of patients had some clinical benefit from this drug. Next slide. And there's phase 3 trials ongoing right now. There's the Destiny breast trial looking at HER2 low tumors. Next slide. Next slide. And the Destiny Breast 06 is actually looking at this as frontline therapy for advanced metastatic hormone receptor positive trials, although there are other Destiny trials, one of which just closed, which look at it for HER2 low tumors that are both hormone receptor positive and triple negative. Next. And I think that's it. Thank you.
No, that's great. I mean, I think what's so impressive about the sacituzumab data is that, we see in early studies that, these data aren't always recapitulated in larger trials. And when you look at the response rate, the response rate really held up in the phase 3 trial when compared to physician choice. And hopefully we'll see additional benefit like that with trastuzumab deruxtecan and the HER2 low population that we will see. Well, thank you. That was a great conversation with a lot of data, just I think representing where triple negative breast cancer is at this moment, and also kind of foreshadowing some interesting things that should be coming down the pike. I want to thank Dr. Press and Dr. Amin and Dr. Krill for their time. And, hopefully this time next year, 1, we'll be together, but then 2, maybe we'll have some additional approvals to talk about with some new agents and some other coming down the pike. Be well.
Thank you.
Thank you.